You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from the heart.org Medscape Cardiology, and this is This Week in Cardiology for April 6th, 2018. This week, diabetes and beta blockers, ACE or ARB first, CID infections, that's cardiac device infections, the holiday heart atrial fib with binge drinking, and the p-value. The first topic today is diabetes and beta blockers. Now, I want to talk first about a provocative study that questions a dogma in medicine, and that is about the benefits of beta blockade. Now, I want to start by saying I'm very sad to tell you that I'm old enough to remember when beta blockers were actually contraindicated for heart failure. I was a medical student at the University of Connecticut, and the late Arnold Katz, Dr. Arnold Katz, he was chair of cardiology there, and he was a leader in showing that beta blockers could actually benefit patients with systolic heart failure, and this was probably through energy conservation means. Now we know beta blockers confer benefit post-MI and heart failure with reduced ejection fraction. But it's also important to note, as both the authors and editorialists of this provocative paper did, that beta blockers have never been found to improve survival in patients with stable coronary disease or in the absence of MI or in the absence of heart failure. But nonetheless, beta blockers are now used like wonder drugs. I have to admit that I like beta blockers because they help with arrhythmia symptoms and because they have a wide therapeutic window. But an observational study published in Mayo Clinic Proceedings by Japanese authors finds that mortality in diabetic patients may be higher in those taking beta blockers. And it wasn't by a little. The hazard ratio in a propensity-matched cohort of beta blockers versus no beta blockers was 1.49, with a confidence interval from 1.09 to 2.04. The authors used the NHANES database during 1999 through 2010, and they matched about 2,800 patients with diabetes with a little more than 14,000 non-diabetic patients. They also made two other observations that sort of strengthened their findings, and this was that the mortality in non-diabetic patients with coronary heart disease and MI was actually lower in patients taking beta blockers, which is what you'd expect if the statistics were real. Now, there's a good editorial associated with this article. Doctors Messerly, Suter, and Bangalore have written this worthy editorial, and in it they set the stage that these findings could be true. For instance, they tell us that the cardioprotection studies with beta blockers after MI were done decades ago before reperfusion therapy. Now, reperfusion therapy and all the other guideline medical therapy that's come about may lessen the incremental benefits of beta blocker. They also remind us that aggressive blood pressure lowering in diabetic patients, remember the ACCORD trial, did not improve outcomes, but aggressive blood pressure lowering in non-diabetic patients in the SPRINT trial did improve outcomes. The take-home of this point is that diabetic patients may be sufficiently different to have a heterogeneous treatment effect, such that beta blockers don't help them. Now, the editorialists also discuss biologically plausible reasons that beta blocker may create harm in diabetics, and that could be weight gain or increases in central blood pressure. And I'll close with the most important point of this finding, and these are the limitations of this sort of analysis. The authors remind us that this is only an observational study, and they suggest that these associations be tested in a randomized controlled trial, which is a good idea, because the biggest risk of this analysis, I'd even say it's likely, is confounding by indication. And what that means is we don't know why the doctors chose to prescribe beta blockers in these patients with diabetes. Maybe the reason they chose to use the beta blockers is the reason the patients have a higher mortality, and it doesn't have anything to do with beta blockers. Remember, propensity matching for patient characteristics is better than no matching, but it's no match for real randomization. Next topic is about ACE or ARBs, and which drug you should use first. The subtitle of this review article is Who Needs the ACE Inhibitors When We Have ARB Agents? And this was the questions asked by Dr. Messerly and Bangalore and others in a review article published in JACC. The authors review the indications for ACE and ARBs, and they compare studies in a sort of meta-analysis. I say sort of because there aren't much in the way of methods. This is really more of a review paper. And the gist of the review is that ACE and ARBs perform similarly well in reducing outcomes in the conditions that they're used for, such as hypertension and heart failure and coronary artery disease. But ACE inhibitors have higher rates of side effects, and this leads to higher rates of drug discontinuation. So this review challenges the guidelines that suggest starting with an ACE inhibitor. Journalist Sue Hughes from the Heart.org Medscape Cardiology got numerous luminaries in medicine to weigh in on the ACE or ARB first question. I enjoyed reading all of these positions. And I don't have the right answers, but I often do start with an ARB, mainly to decrease the odds of a drug side effect. Because more and more in my career, I think about decreasing the work of being a patient. So if a patient gets a cough with an ACE inhibitor, it doesn't seem like much, right? But that's just more work he or she has to do to be a patient. They have to call me and tell me about it. That means they have to get through the morass of our phone system. Then they have to get a new prescription. Then they have to go to the pharmacy. And so it just increases the workload when the first drug has side effects. Next topic are device infections. I think one of the most important concepts in all of electrophysiology is that reoperation of a cardiac device should never be taken lightly. Generator changes and lead revisions make me seriously nervous. An observational study from multiple authors in the multi-center electrophysiology device infection cohort, or MEDIC cohort. It's a prospective registry of patients with infections of their device, and it's at 11 international sites. They published a paper in Open Heart and found that pocket infections were more likely to occur after reoperations than after new implants. And the causative bacterial organism differed. In reoperations, the more likely cause was coag-negative staph or staph epidermidis, whereas in new infections, it was more often staph aureus. Now, the likely cause of higher rates of infection in reops are that patients were sicker. In this study, for instance, the patients in the re-op group had a higher comorbidity score. Now, this is sort of the point. The patients for reoperation are sicker, and things have changed since the initial implant. Mainly, they've gotten older and they've had more time to get more diseases. And so one of the biggest gaps in EP is that we don't have an RCT, a trial of ICD gen changes. Now, think about this. Because the risks of reoperation are higher, and because the patient has gained competing comorbid conditions, I have little doubt that the net benefits of generator changes with ICDs would be less beneficial than the initial implants. We've really got to discuss this issue with our patients. Now, finally, I've seen these coag-negative staph pocket infections and have been tempted to try to clean them out and salvage the pocket. I know that sounds crazy, but when you open up the pocket, it's just isolated to that pocket area and the other surrounding tissue seems clean. Now, I've not done this. I've not tried it. I've not been gutsy enough to do it. But in the news story is a link to a group that has had success doing it. I still think it's best to extract the system, but if you disagree or you have had some experience with salvaging pockets, by all means, leave a comment on the bottom of the podcast. Now, the next topic is mechanism of atrial fibrillation from binge drinking. This is an interesting one that has some basic science in it. Investigators from Rush University and colleagues performed an elegant series of experiments on human donor hearts who had a history of binge drinking. They also did animal experiments to connect the causative link. They first found AF inducibility in the myocytes from the human donor cells that had a history of binge drinking. Then, making the causal link using the animal experiments, they found that alcohol exposure led to activated JNK2, which is a kinase known to be activated by stressful stimuli such as aging and diabetes. Now, the link was related to enhanced JNK2 signaling, and that led to enhanced aberrant calcium release. Then the authors used immunoblotting experiments, and they measured an increase in phosphorylated JNK2 in response to alcohol exposure. And then blocking JNK2 in vivo with a mouse knockout model and in vitro with blockers reversed AF inducibility and the associated calcium dysregulation. Then they established a link between alcohol-triggered enhanced JNK2 signaling and the well-described pro-arrhythmic molecule calmodulin-2, known for driving sarcoplasmic calcium mishandling. And so for the first time, the authors could show that alcohol-evoked JNK leads to augmented calmodulin-2-driven sarcoplasmic reticulum calcium mishandling, which ultimately enhances atrial arrhythmogenicity. Remember that one of the mechanisms of AFib is abnormal calcium signaling within the cell, which leads to DADs, delayed after depolarizations, and AFib. Now, connecting this whole thing to a possible therapy or therapeutic target, the authors showed that a JNK2 inhibition blocked the abnormal calcium mishandling, and that suggests a potential antiarrhythmic target. Now, I'm sure that I'm not doing this basic science justice, but it's good to have an explanation for alcohol-related AF, not because it helps clinical care of binge-related AF. I mean, clinical care of this condition is easy. You just recommend patients don't binge drink. But I like this study because of the elegant experiments and because I didn't know much about JNK activation before reading this, and I learned something. And anything that sheds light on AF mechanisms is worthy of our attention. Now remember why AF drugs and ablation are so bad. They're bad because we don't understand the basics of the condition. The final topic today is on p-values. When Professor John Ioannidis of Stanford speaks, it's good to listen. He's the author of the most downloaded scientific paper of our time, and it was titled Why Most Published Research is False. And Ioannidis recently wrote an editorial in JAMA about changing or lowering the level of statistical significance from a p-value of 0.05 to a p-value of 0.005. Now, first off, we should set out that the p-value is not the likelihood a finding occurred by chance. Rather, a p-value is the chance that one sees such results if the null hypothesis is true and if there is no bias. Ioannidis thinks we need better measures of treatment effect. Odds ratios, relative risks reported with confidence intervals would be better expressions of treatment effect, he says. He says that you can have a very significant p-value but a very small treatment effect. I was surprised to learn that he thinks we would abandon the p-value in about 80 to 90% of the medical literature. He thought the move to more stringent standards was absolutely needed for observational studies, even calling the p less than 0.005 level probably very lenient for observational studies. The thing I like about this shift is that it would move about a third of the biomedical findings from certain to merely suggestive. Having seen many medical reversals over the past decades, I completely agree with a slower rate of adopting new drugs and procedures. Steve Stiles has a great news story of this important editorial. There's lots of good translation of the complicated statistics. Take a look at it and think about this last topic. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.